Welcome to our discussion on BACT-URIE, a novel score integrating bacteriuria to predict infective endocarditis in Staphylococcus aureus Bacteremia. This major article by Péan de Ponfilly et al. Is published in Open Forum Infectious Diseases 2026. Staphylococcus aureus Bacteremia, SAB, is a major cause of bloodstream infections, often leading to infective endocarditis, i.e., in up to 20% of cases. This significantly worsens outcomes. International guidelines recommend echocardiographic evaluation for all SAB patients, but this is resource-intensive. Notably, current tools like VIRSTA and PREDICT overlook bacteriuria as a predictor. Up to one-third of SAB patients have Staphylococcus aureus bacteriuria, often dismissed as contamination. However, without urinary symptoms or recent procedures, it may indicate hematogenous seeding. Our key hypothesis is that Staphylococcus aureus bacteriuria predicts infective endocarditis in SAB, warranting its inclusion in clinical decision tools, a gap BACT-URIE seeks to address. The study design includes adults aged 18 and over with at least one positive blood culture for Staphylococcus aureus. Urine cultures were obtained within 24 hours, and all patients underwent transthoracic echocardiography. Key exclusions were confirmed primary Staphylococcus aureus urinary tract infections, adjudicated by specialists using clinical, microbiological, and imaging criteria. Multivariable logistic regression identified 5 independent predictors of infective endocarditis. These include intracardiac device, community-acquired Staphylococcus aureus bacteremia, Staphylococcus aureus bacteriuria, septic emboli, and persistent bacteremia. Scores were assigned based on odds ratios, with Day 1 scores ranging from 0 to 12 and Day 4 scores incorporating persistent bacteremia, ranging from 0 to 15. The BACT-URIE scoring system evaluates infective endocarditis risk. Day 1 scores range from 0 to 12, with key variables like intracardiac devices and septic emboli. Day 4 scores, ranging 0 to 15, add persistent bacteremia. Optimal thresholds are Day 1 score 2 and Day 4 score 3, based on the Urine index. Discrimination performance was good to excellent across cohorts. The validation cohort showed higher area under the receiver operating characteristic curves than the derivation cohort, 0.91 versus 0.78 on Day 1, and 0.93 versus 0.81 on Day 4. This reflects a higher proportion of patients with septic emboli and bacteriuria, enhancing discriminative performance. At optimal thresholds, the score shows high negative predictive values, 93 to 98%, useful for identifying lower-risk patients. Day 1 and Day 4 validation cohorts show improved sensitivity and specificity. However, higher thresholds increase specificity and positive predictive value, but reduce sensitivity, necessitating careful clinical interpretation. This slide presents a head-to-head comparison of BACT-URIE with VIRSTA and PREDICT. These comparisons highlight cohort-specific characteristics and should not be seen as evidence of uniform superiority. Independent prospective validation is crucial before making definitive conclusions. The BACT-URIE score aids clinical decision-making, but should not replace clinical judgment. Always prioritize clinical signs like new cardiac murmurs, acute heart failure, or hemodynamic instability over score-based recommendations. The BACT-URIE score's strengths include its novel use of Staphylococcus aureus bacteriuria as an infective endocarditis predictor, validated through rigorous methodology and low verification bias. However, limitations exist due to its single-center retrospective nature, COVID-19 era overlap, modest infective endocarditis event numbers, and non-systematic transesophageal echocardiography use, affecting generalizability and score performance. BACT-URIE is a pioneering score integrating Staphylococcus aureus bacteriuria as an infective endocarditis predictor, showing high negative predictive value. It aids early risk stratification, but should not replace clinical judgment. Prospective multi-center validation is essential to assess its real-world impact before recommendations can be made. Routine clinical use.